Hello, everyone. Welcome to another insightful session organized by Apollo Fertility. Our topic for today is fresh versus frozen embryo transfer. We would like to welcome Dr. Alikya Reddy, who is our in house infertility specialist. She holds a degree in MS OBG, IMA Fellowship in Infertility, and Masters in Reproductive Medicine and IVF from London. Welcome, Doctor.
Hi, hello. Today we're gonna throw some light on fresh versus frozen embryo transfer, as many of our patients have a lot of doubts on it. That is it okay to go for fresh, or is it okay to go for frozen? So I'm gonna discuss pros and cons of both, and I'll give you a few hints, and then you can take your call accordingly. But mainly it depends on the doctor, on the treating doctor, embryologist, and the conditions around you. All right. So when IVF was developed initially, we didn't have an option of frozen. The only mode of transfer was a fresh embryo transfer. So now, because of science, cryopreservation, freezing, the embryos can be still used for a future use. Yeah. So if we go, when we see the history of freezing human embryos or gametes. In 1949, first human gamete preservation, that is sperm vitrification, was done. In 1984, first live birth of FET was done. In 1985, first pregnancy with the third blastocyst was seen. In 1986, first live birth with third oocytes was seen. In 2004, we noticed the pregnancy rate of frozen embryo transfer was as good as a fresh embryo transfer because of the development in the freezing methods and the vitrification and all. As I mentioned, the third blastocysts and third oocytes. So, what are third blastocysts? So, those are the embryos which reach day 5. It is known as blastocysts, and they are frozen, and then they are thawed. And what about the third oocytes? In this case, we freeze the oocyte itself. So, we develop the oocytes, that is the eggs inside. We retrieve the oocytes and then freeze them. So, that is it. And so, what is fresh embryo transfer and what is frozen? In fresh embryo transfer, as you know, in a normal IVF process, we give you certain medication, hormonal medicines, which starts from day 3. The stimulation goes up to 9 to 10 days, and then and then we monitor the stimulation via your blood test, the investigations that could include estrogen, progesterone, LH, and others. And we even monitor it through the follicle sizes, which are seen on the ultrasound. So once we feel the ultrasound has enough number of follicles of the correct size and the blood tests are to match with it, we plan for a trigger. So once the trigger is given, after usually 34 to 36 hours, the oocyte retrieval is done. So once the retrieval is done, the oocytes are out with us. We take the husband's sperm and we perform the ICSI. So now the embryo starts get forming. Okay. So the embryos are prepared in the laboratory. In that, if we are doing a fresh transfer, then it would be done 3 or 5 days after this process. Like after the OCR, OCRD is day 0. From next day, we'll count it as day 1. And so we do it after 3 or 5 days. That is again depending on the prerequisites, depending on the conditions and condition of the patients. And we will discuss about it. So if the embryo transfer is done immediately in the IVF cycle, after day 3 or day 5, it is known as fresh embryo transfer. And if we are freezing the embryos and using it afterwards, it could be after 6 to 8 weeks, after a few months, or after a few years, then it would be known as the frozen embryo transfer. All right. So, yes. So, when do we suggest to go for frozen or fresh? The indications. So, the indication for a frozen embryo transfer would be if the P4 level in a fresh cycle was high, if because of the stimulation, if we had more number of follicles in the fresh cycle, in the IVF cycle, to prevent OHSs, that is ovarian hyperstimulation syndrome. uh, to prevent superovulation, to reduce the risk of OHSS, we can go for frozen embryo transfer. In case of leftover embryos, so suppose you had more number of embryos in your hand, you've transferred a few, and there are a few embryos left, those can be used after the frozen because the cumulative success rate could go up. In case the patient had any pregnancy loss with the initial embryo transfer, then we can go for frozen. Again, in case of the second child, like in this cycle itself, we attain more number of embryos. So we're gonna transfer a few and transfer, and we're gonna preserve rest of them for the future use. In case the endometrium wasn't optimal in this cycle, the endometrium layer has to be optimal. We're gonna discuss about the quality and it should be usually 8 or above. It should be triple line. It should be free of polyps. It should be free of any other echogenicity. Then only we transfer the embryo. If we have any of such condition, we can wait and go for the frozen embryo transfer. Another important point would be a PGS or PGTA, that is a pre-genetic screening. In case they had any abnormal children before, or they had recurrent implantation failures, or they wanted to check the chromosomal abnormality or genetic testing in the baby. It is known as PGS. In that, they take the embryo biopsy. That is a small part of the a few cells from the embryos are taken and they are sent for the DNA check. And once the chromosomal and genetic testing is done, which takes a while, so then you can't do a fresh transfer. You need to again freeze them and then thaw them and then transfer at the right time. and uh, and yeah, these would be basically yeah, in some cases of adopt, because then normal adoption, few people want to carry the child, then there is something known as embryo donation also. Again, it has its own laws and we have to follow every protocol and then follow it. So in case of embryo donation also, the frozen cycle is preferred, because the embryos are already frozen. So yeah, they are not discarded if they are of good quality, and if they are not used with the consent of every individual, we do transfer that as well, right? And how about, okay, so if you want to know about the endometrial lining in a fresh embryo transfer, as we improve the follicle sizes and we give the medication for the ovarian stimulation, that itself produces a bit of estrogen and that prepares the endometrium lining. Whereas in frozen, there are different set of protocols which has to be used for the preparation of the endometrium. Yeah. Now, the major question which comes into everyone's mind is, how are the chances with fresh and frozen embryo transfer? So, to be honest, as I mentioned earlier, also before 2004, everyone preferred fresh embryo transfer because they were not sure about the frozen, about the techniques, about the cryopreservation or the vitrification and the thawing and everything. But nowadays, we have seen they both are in par, so we don't see a lot of differences. In fact, there have been a few studies done. We in our own fertility center, we have done studies on a small group of patients of around 500 to 1000, which we are about to publish as well. And there are a few studies done in the USA where they have taken around 4 to 5000 patients and they have compared. So what all did we compare was, we compared if first of all the success rate was equal, then, if at all it was successful, the number of abortions or the ectopic were again equal. The chances of preterm labor was almost the same. In some cases, we saw in the in the frozen embryo transfer, the preterm labor was a little on the higher side. The baby weight was the same. Small for gestation age was the same. The Apgar score was almost the same for both. So in the and we are still the larger studies are awaited to evaluate the comparison, to evaluate if fresh or frozen are better. But so far we felt that it's almost the same. But one thing which we noticed in our center was, when we stimulated the higher responders and we had more number of eggs and then more number of embryos were formed, in those the frozen embryo transfer really helped them conceive. It could be because of obvious reason, because of slight OHSs or anything, but that was our observation. And patient with lower reserve or low responders, in those patients, the fresh embryo transfer helped us better. Anyway, we were not left with a lot of embryos to do the frozen, but this was one of the peculiarity we observed in the study. Yeah. Uh, I would definitely say chances of getting pregnant by fresh or frozen embryo transfer would be the same, because the technology used to freeze and thaw has advanced so much that the likelihood of embryo surviving process has increased definitely. Yeah. Now, if you want to know just the principle of freezing, so we store in liquid nitrogen at minus 196 degrees, and suspend animation, no metabolic activity is used. To move the embryo from 37 degrees, the room temperature, to minus 196, we need to use some non-toxic cryoprotectors to prevent cold-induced damaged cells, which might result in the exposure of low temperature. And when do we do the freezing? So freezing can be done from day 0 to day 6. In our clinic, we usually observe till day 3, and in some patients, we even observe till blastocyst. Till day 3, if we feel it's fine and it's going to survive, so we freeze it on day 3. And in some, we wait till day 5 for the blastocyst to get ready, and then we usually prefer preserving the embryo only if it's grade A, because then only the chances of conception would be more. Grade A to B maximum. If it's worse than that, then I would suggest a freezing, because that again depends on the embryologist, because they are the best ones to say. But we don't think that can withstand the procedure of freezing, thawing, and everything else. And one good quality of blastocyst is also there. We would definitely ask to preserve and freeze because of the future use. And of course, an informed consent has to be taken by the patient, and only if they can afford it also, then only we go ahead with it. And only if we are sure that the embryo is going to survive, then only we go for the freezing. All right. Now, the benefits of frozen embryo transfer. So the benefits of frozen embryo. So endometrium receptivity is more in frozen as compared to fresh in some cases, because here in a frozen embryo transfer, we are concentrating only on the embryos. We are not worried about the ovaries. We are not worried if the oocytes are increasing in size or not. So sometimes the receptivity is more. The chances of OHSs obviously comes down, so that again, and the risk of because of frozen embryo transfer, now we have chances of less multiple births, because we won't transfer too many embryos in the fresh cycle thinking we have to just finish it now. So you can just transfer one or two in the fresh cycle, and then you can preserve the rest for the later, so that the success rate, the cumulative success rate, can also go up. um, I think those would be the only benefits. And now coming to ET preparation, endometrial preparation. Yeah. So endometrium preparation can vary from patient to patient. In some patients, you might observe the natural cycle is only better. In the natural cycle only, patient develops good endometrium. So we won't put a lot of estrogen. We won't put a lot of hormonal medication. We're gonna just support it with folic acid and minimal basic blood thinners like ecosprin and basic medication. Otherwise, in other patients for frozen embryo transfer, the most common drug which is used is estradiol valproate, that is 2 mg, which we start from day 2 or day 3. So on a day 2, day 3, we need to check for the scan, check if there are no cysts and the endometrium is fine, it's shedded well. Then only we start with estradiol valproate, and which we gradually increase the dose. And at the right time, when we feel the endometrium reaches almost 8 mm, triple line or more, and which has no echogenicities or no polyps, then we feel that it is a good time for the transfer. Then we start the injection, the progesterone injection, which goes for almost 5 days, and then we plan for the transfer. For the poor lining, in case the proganova has not, we are not able to get the lining by proganova, then we can mimic the stimulation so that the endometrium increases. So for that, you can use any normal medication like clomiphene citrate or letrols, or you can add a few injectables to them, and then try to grow the follicle, because the endometrium will grow along with the follicle. But then once the follicle is increased, you need to give the trigger for it to rupture. Only once it's ruptured and the endometrium is ready, again you start with the injections, and then after day 5 you need to do the transfer. And the most important part is P4. You need to really monitor the P4 and then only go ahead with the transfer, E2 and P4 preferably. Yeah, and there are a few injections, the GCSF injection, which we give 300 subcutaneous. That's again helping in improving the endometrial lining. And if you have constant poor lining or thinning of endometrium, then hysteroscopy would be one of the option where you can see through the camera properly if there is any other problem that the endometrium can improve. And then we have usually seen after the hysteroscopy the chances of embryo transfer, the chances of pregnancy, live pregnancy rate has gone up along with the hysteroscopy. And when else do we do the hysteroscopy? If you see any polyps, mainly. So you need to convince them to undergo polyp, because polyp can be a physical hindrance for the endometrium to accept the embryo. The embryo to get attached to the endometrium, it can be a physical hindrance as well. And again, the hormonal disturbance can be there because of endometrium, because of the polyp. Now, after the transfer, we give a luteal phase support, which is very, very important, because always remember, when the body is undergoing a natural process and naturally everything is produced within the body. But when you are mimicking a natural cycle, or when you are trying to do everything from outside, then you really need to support the pregnancy even after the embryo is transferred. So, in that, mainly the progesterone. So, some prefer the vaginal progesterone because of the direct absorption in mucosa, but the others would even suggest painkillers, or not the painkillers, sorry, injectable progesterones, or the gels or anything. Plus the other supplements, if you have started the estrogen like Proganova, the estradiol valproate, then you need to continue it till you are giving the progesterone, so that you don't have any bleeding or spotting in between. You can use some blood thinners along with it. You must use folic acid that you know already. So these are a few. And so while I was going through this, I have gone through this very interesting thing. There's this Cato, that's the world's biggest, I would say the busiest IVF center. So, like a gold standard, they have opted for no fresh transfer, freeze all, only elective freezing, frozen embryo transfer. Only blastocysts are transferred, and only vitrification is done. So I thought that would be interesting to know, because it's the busiest IVF center. But again, every center has its own protocol, and every doctor knows what's the best for the patient, and even the clinic protocols, and even the embryologist. So we are no one to question them, but then yeah, these are a few things you can keep in mind. Even in the donor cycles, like sometimes when you have a very low ovarian reserve, and some people, as you know, go ahead with the donor oocytes. In that also, both can be used, like frozen or fresh. But fresh is very rare, because your cycle has to almost merge with her cycle. It has to go parallel, so which is very difficult sometimes. So here also we do frozen embryo transfers, and the success rate is quite high. So yeah, I would conclude saying that both of them have almost equal success rate, so you don't have to worry much about it. All right. So we can go ahead with any questions or any queries. Uh, I would be happy to answer them.
Hi, thank you, doctor, for a really good insight about all this, all the frozen and fresh embryo. I hope the audience have learned and they might come forward and take take the step. So we have gathered some questions which the audience have asked us previously. So I'll just read out one by one so you can answer it. So one is that I think you've already mentioned. Does the success rate differ in the two processes?
Yeah,
So,
usually it's almost the same. Yeah, the success rate has nothing to be done by fresh or frozen. Anyways, in if at all there was OHSs or if there was more number of eggs, then we would not go for a fresh transfer. We go for frozen because we have seen the fresh transfer usually gets declined or the situation becomes worse there. So the success rate is the same for both. Yeah.
okay. Next is, do fresh and frozen embryo have to be, compulsorily collected during the ovulation period?
Okay. Ovulation period. No, so that see here what happens in IVF, we are giving you the injections. So the ovulation will differ depending on the injections we are giving. So we gonna it's depending on the scan findings and on the blood test, we decide what time the retrieval has to be done. So once it's done, it's only after that the embryos are taken. And as I told you, the XE is done the same day. So IVF XE is done the same day and later on we plan if we are transferring fresh, then it's transferred on day 3 or day 6, or if it's frozen then we wait and then we can transfer it any time, and the duration is also you can freeze it for how many ever years you want.
And are these process painful for the?
Uh, Embryo transfer is usually not painful. It could be a little, you might have a little discomfort because you need to have your bladder full during the embryo transfer. So, slight discomfort can be there, but it's not painful at all. It is very simple. Yeah. You don't even need any anesthesia or any sedative. It's done very naturally. Yeah.
Okay. And so, is there any age restriction that is there to, freeze your eggs or get an embryo transfer done?
For embryo transfer, I would not say any, but I would still suggest below 42 years is better. 42 to 43 years is better for embryo transfer. And freezing of eggs is always better 25 to 35 years because that's when the reproductive age group is. So, but again, it depends on patient to patient. Some people end up in premature ovarian failure, so the eggs won't last longer. So then in those patients we need to retrieve the eggs much before. But in case of PCOD and all, even at the later ages, like even if they are 35, 36, 37, they have more number of eggs. So there is no particular age group, but it's always better to, if at all you have any professional commitments or you didn't find the right partner or whoever, then you go for oocyte retrieval just before 32 years. Preserve your oocytes, and later on when you find the partner, we can do the ICSI and do the embryo transfer. Or if you have a partner and still you don't want to go for the children right now, then it's always better to freeze the embryo. So you can freeze the embryo and then you can go for the child whenever. So in that way, even the age of the oocyte is quite young. So the number of chromosomal abnormalities or the genetic abnormalities would come down. So that's an advantage. Yeah, it's always better to do that. Yes.
With COVID-19 vaccination and everything, we hustle about it. People also have asked a lot of queries have come in regarding is COVID vaccination safe before or after the embryo transfer process?
Of course, of course. So we don't have a lot of studies, but so far, whatever we've done, it's always okay to go ahead with the COVID vaccination. But if you have a timing or something, then I would rather say that you go for retrieval, and then if you are going for the embryo transfer, wait till you conceive, and after third month, it's safer to go for the vaccination. just because we don't have much studies right now. And initial 3 months of the pregnancies are the most important. So if you don't develop any abnormalities, usually you won't develop post that. So I think that would be the best thing to do. But then we haven't seen any problem or any hindrance with the vaccination. So definitely you can go ahead with the vaccination. Yeah. In fact, in abroad, they allowed even the pregnant or the lactation patients to go ahead with the vaccination. So that's what we are encouraging here as well. So yeah, no problem so far.
So, any precautions or diet that people should follow before or after the transfer is done?
So there are no musts that you must take it. We don't have any such diet, but it's always better to have a healthy diet for a healthy pregnancy, for a healthy implantation, and all of that. We would always suggest to include a lot of dry fruits, a lot of fruits, a lot of leafy vegetables, which adds nutrition to the body, and keep your iron calcium levels all at the level. So no particular diet per se, but then yeah, of course, avoid junk food, avoid aerated drinks, avoid um, yeah, you just need to avoid those, and nothing in particular. I think this will help quite a bit.
Okay.
Yeah.
Uh, Also, the one person has asked that is it true that in case of frozen embryo transfer, the doctor can select the one which has the most chances to work?
Oh, no, we had that. No, but then yeah, as I mentioned in my talk also, there is something known as PGS or PGTA. That is a genetic screening or genetic testing of the embryo. So when they have chromosomal abnormalities or any genetic changes, so in that we might get to know the best of the embryo. Otherwise, there is nothing. We are freezing only the best of the embryos. We freeze it only if it's a blastocyst and only if it's AA and AB. So we assume that we have greater chances. So, but it's not that we're gonna, yeah. For any, even if it's a fresh embryo transfer, you're gonna choose the best for you. So either which ways, we have to choose the best embryo and transfer. Yeah.
That's good to hear. Also, the embryo one query that has come in a lot is that is one transfer expensive than the other?
Expensive?
Yeah.
Expensive. Okay. So, see, I'm not sure. Of course, the frozen would charge extra, right? Because of the freezing charges, because of the laboratory and the products they are using. So that goes, yeah, definitely it goes up. The expenses go up, but I'm sure it's worth it because depending on your cycle and depending on the person, we suggest the um freezing. So yeah, the freezing charges would be definitely extra. I would not say it would be way too expensive, but it would be extra than the normal fresh embryo transfer. Yes. Yeah.
Okay. Also, can more than one embryo be transferred at the same time?
Yes. We transfer around two because if both get implanted, then it's twins. And very rarely three. Very rarely where we see like two have the more chances of surviving, and the third one would not. So yeah, and why to discard it because you never know. So very rarely three, so that the chances are more of at least conceiving with one child, but not more than that. Usually two is one or two is the basic protocol we follow. Yeah,
So when
because if they really don't want to go for multiple pregnancies, then we would not even transfer two. Then we stick to only one. So yeah.
so it depends on the patient's idea of what they are comfortable with.
The number of embryos we have, the quality of the embryos, and the chances of getting conceived by those embryos. So, taking everything into consideration, also your endometrial layer and also your uterus, because some people have smaller uterus, so they might not be able to accommodate more embryos. Because if they grow, then if the child is growing, the embryo has to get into the fetus. So, if it cannot accommodate the more number of fetus, so then we transfer only one. So, there are various factors, But yeah, practically we can transfer more as well. Yes.
Okay. So, PCOS and PCOD, do they have any role to play in terms of the success rate? Like, if you have a PCOS or PCOD, will it be a difficult?
There is no particular role to play in that. So in PCOD, as we keep mentioning about OHSs, that is ovarian hyperstimulation. So yes, in PCOD that is very common. That's why many a times in PCOD, you must have heard that they had told that we're gonna freeze all and then we're gonna go for a frozen embryo transfer. That is one of the factor in PCOD, but nothing to do with the success rate. It is as normal as any other patient. You don't have to worry. But again, the PCOD has, so that's another topic altogether. So
Yeah.
usually it doesn't have. But then if you have severe PCOD or mild, then those things vary. Yeah.
So the last question is that how many eggs can individual freeze at a time?
Feed, you mean
Freeze,
grow?
freeze. No.
However, how many ever we get? So they have cryologs, and I think if it's the embryos, they put only 2 or 3 in each cryolog. But how many ever eggs or the embryos are found, they can freeze all. There is no limitation to it. But definitely the expenses and the number of cryologs and all of those might differ. But that has to be spoken with the embryologist. But there is no restriction to it. How many ever can be frozen?
Okay, so that was the end of the session. Thank you so much, Doctor, for joining us today. And I hope people would like to hear more about this, and we'll get a
To leave the questions and then we'll get back.
sure, sure, we'll definitely do that. Thank you so much. Thank you, everyone, for joining us, and we'll see you all in the next session. Thank you.